Hi guys, John Adams, the Rehab and Documentation Guru. Sorry for the weird angulation of my phone, but I'm kind of chill, reclined in my car on this beautiful day that we're getting, in Virginia at least, a taste of fall weather, which is just welcome, definitely welcome. Um, Doing documentation, and I want help. I want help from all you knowledgeable therapists out there. I think I've got a sense about this patient, but and what might be going on. But here's the scenario: my patient, she's elderly. Let's say she's into retirement age. I don't want to give away too much that might be potentially construed as HIPAA violating, but I'm going to tell you stuff that could be any case study now, so it won't be HIPAA related. Anyway, she's a lady who's relatively healthy normally. She's living on her own. She's retired, very active, cognitively intact, owns her own home. Her only diagnosis prior to what's happened in the last couple months was high blood pressure. And the way it was indicated was high blood pressure related to stress. Like when she gets stressed, she gets high blood pressure, which always makes me wonder, like, how did they determine that? Did the patient walk in, got a blood pressure, and said, oh, your lab coat makes me stressed, and so you get the lab coat syndrome? How do they determine that only stress brings about the high blood pressure? So that's suspect. Anyway, what happened to this lady who is normally functioning well and reporting to me that prior to July, middle of July, she had typical aches and pains here and there, but nothing significant. And then she wakes up one July morning in excruciating pain in both shoulders at the same time. So nothing on the prior day that she can recall that caused this. Just wakes up in incredible pain. She goes to the hospital and they do testing and they do x-rays, and they discover at the same time she's got a hiatal hernia. Significant enough they want to do surgery. So they treated her with some meds, but basically eradicate the pain. They send her home. The pain then migrates from her shoulders down to her hands. And what's been happening lately is her hands are getting incredibly swollen and painful to the point where she's got minimal grip. One hand, she can barely close her hand, about like that. She does have full thumb movement, so she can oppose her thumb all the way to the pad of her fifth met. But it's tight and it's painful. Both hands. So one hand's a little bit more impacted than the other, but it's bilateral and mostly symmetrical. Both shoulders are now limited. And they are uncomfortable. Like she gets to about mid-range, she can't move them. This is kind of an unusual one for home health. Normally you'd see this kind of person go to outpatient, but the doctor gave her the option, which really is not the doctor's perspective, and I'm trying to justify homebound status because she cannot drive, doesn't have necessarily the help to drive her places all the time. And she's needing help to wash her hair. She can't open her pill bottles by herself. So there's problems going on from an ADL perspective. So anyway, this is an interesting case, right? What's going on with this lady? Well, we know it's systemic. We know it's not an isolated joint issue. So I do typical screens, and like all home health therapists, you look at things like vitals, and I'm looking at her vitals, and she's in the 140s over 90s at rest, sitting. And I wasn't stressing her out. We were just sitting chatting. We were yucking it up a little bit. Very pleasant lady. So I'm not going to chalk that up to high blood pressure or just under stress. So she's got hypertension. Okay, so that's one piece to the puzzle. She's got heart rate is in the 80s, so it's a little faster than normal, but it's not tachycardic. Her respiration is fine. She's not short of breath. She's got no distal lower extremity edema. She denies orthopnea and platypnea. She denies dizziness when she arises. She denies paroxysmal nocturnal dyspnea. So these are all questions I'm asking because I'm trying to establish, is there something systemic going on, and so I'm trying to rule out maybe a possible cardiac issue. Okay, so she's got that going on. She's also short and somewhat rotund. Not terrible, but let's just say it's for a female, she's got greater than a 35-inch waist. And I asked her if she had any history of diabetes. No. I asked her if she had any numbness or tingling. No. Except for her hands. Like, she wakes up in the morning, both her hands are numb and tingling until she gets them moving, worked out, and then they get better. So we might be able to chalk that up to swelling. I asked her if she's going to the bathroom during the night. She said yes. How often? 2 or more times per night. Okay. How about excessive thirst? No excessive thirst. Are you going to the bathroom a lot during the day? No. Any numbness or tingling in your feet? No. But I noticed when she's walking, she's got everything else tests fine. I mean, she's great. Walking without a device, goes up and down stairs outside. But she's got a slightly widened base of support. Slightly. Maybe there's a peripheral sensory issue going on. Maybe. A slight. What else can I point out to you? Now, she does tell me in the course of this interview, which I didn't get from the doctor, I got diagnosed with rheumatoid arthritis. I said, okay. That makes sense, systemic issue. She's got no ulnar drift anywhere, no significant changes, although she's starting to get, and I forget the name of that deformity. Somebody's going to have to help me out with that. Normal resting like that, but that could also be, I don't know, could it be maybe inflammation's causing her to want to sit up more like that? But you notice what else I notice about her hands, because I'm looking at her hands a lot. She's got clubbing of her fingernails. Clubbing. And I, in my note to this PA, or nurse practitioner that sent the order, I do note that she has clubbing of the fingernails, not accounting, she's got one finger she had a partial amp on, and it grew her nail in funny. This has been associated with, so clubbing is associated with cardiac issues, metabolic issues, endocrine issues, certain cancers, and gastroenterological issues. Now, one other thing that comes up during the eval is that she is on, she's on Prevacid, but she doesn't say she takes it all the time. And what do we know that for? We know that is something used for reflux. And of course, she's got the hiatal hernia, so yeah, that makes sense that they would go together, right? So what else can I note about this lady? So anyway, what am I thinking? What am I thinking's going on? Well, as somebody who was pre-diabetic but acted physically like I had full diabetes, like multiple episodes of nocturia, which is just getting up to pee during the night, I felt terrible. Oh, she's also generally fatigued. Terrible after meals. Just, it wiped me out. High blood pressure, waist circumference almost 40, which for a male about 40 and above is considered dangerous. What else was going on with me? My cholesterol was out of whack, etc. In other words, I was showing the signs and symptoms of metabolic dysfunction or metabolic disorder. And I suspect this lady, even though she's got no history of it, she is on the verge of diabetes, or maybe, over that. I asked if she'd ever had an A1C. No. Now, why is all this important? Why delve into this kind of stuff with her? Well, the reason I'm delving into it is because there's a high correlation between metabolic dysfunction and general inflammation. And when we have somebody that has an inflammatory disease like rheumatoid, yeah, we as therapists can do stuff for them, but unless the root cause of the inflammation is addressed, what we do is just going to be putting a Band-Aid on a problem. And I'm trying to paint a picture for this nurse practitioner without telling her what to do, that this lady needs to go to a rheumatologist. And I asked, do you have a rheumatology visit scheduled? well, no, I'm going in for this repair at my hiatal hernia, and I guess we're waiting for that. And I'm thinking, why wait? You get this active inflammation. The longer it goes, the more damage to be done. There's a lot of obviously pharmacological things that could be done for rheumatoid. But I started talking to her about anti-inflammatory diets. And one of the things that has come up recently in research is that there's a growing incident of adults developing dietary issues, or I should say gastroenterological issues, like Graves' disease. What's the other common one? I'm just blanking on right now. But adult onset of these digestive issues that cause food basically to become a poison to your system, and you develop general inflammatory processes. And so she's got inflammation. It needs to be addressed. And really my job is to be, hopefully in this case, a guide towards hopefully the correct path of treatment. And then I'm going to look at some other things that I'm going to possibly do to help her out. But anyway, just a really interesting set of symptoms, and it just makes me realize she's way underserved, probably from the medical perspective, just not being thoroughly looked at as a person with a whole set of symptoms. So I suspect she's either pre-diabetic. She's definitely probably got, if her lab values come back with the wonky cholesterol profile, she's got metabolic syndrome. That ups your inflammatory markers quite substantially. That combined with hyperinsulinemia, there's a growing body of research that suggests that it's not so much the high glucose that's the issue, it's the hyperinsulinemia that causes problems of metabolic dysfunction and problems with inflammation and whatnot. And then, of course, what do you do with diabetics that, pills don't work for? You give them insulin, and you further increase their hyperinsulinemia, and it's just a vicious cycle. So I suspect if they address what's probably a metabolic dysfunction with her, which can cause all of the symptoms we've just talked about, then she'll do a lot better. So what did I do for her? Well, I talked to her about elevating her hands. She's got nothing in terms of like compression gloves for the edema. She's not on adequate pharmacology. I brought that up to the doctor. I suggested maybe getting assessed by an orthotist for like, Job's gloves or something like that. With her, I wouldn't want just anybody prescribing those. I told her about contrast baths, and I informed her how to do that. I used to have Dequervain's tenosynovitis and carpal tunnel both hands when I was doing outpatient ortho in the 90s, and that was the only thing that helped me get through the next day of work was contrast. I've told her to avoid, overuse of the hands, and I also asked her to keep a diary of what foods she ate, and then how did she feel like a half hour or so after she ate it. And we know that when you ingest carbs and whatnot, generally your spike in your blood sugar is going to happen in about that first half hour mark. And so knowing that, how those foods make her feel might point to, is there a food component of inflammation, which I'm going to guess there is. So anyway, hey, if you have any comments or suggestions, please leave them. Interesting case. I've been just thinking through it, and I'm sending this huge note to the nurse practitioner who may think I'm the stupidest guy in the world or the smartest guy. I don't know. Anyway, hope you're having a great day. Take care, and God bless.